I thought it'd be worthwhile to really focus on medical decision making because so much goes into that. And if we can come at that from a shared place of mutual understanding and commitment to the next level, I think that is key. So let's explore that. And then I also want to go over some clinical pearls based on some research that I find most effective, just to share those with you. But before we decide on what to give, let's decide on what's the best way to make a decision. When we went and taught at the VA, we used this ECHO model, and it's pretty simple. Four things. E is for efficacy. Some people also might call this evidence of benefit, but E is for efficacy. C is cost. H is harm. What's the evidence of harm? We often look at the evidence of benefit, but we don't look at the evidence of harm. And O is opinion. So what's the opinion or that bias or that implicit bias of the person we're serving? If someone is fearful of acupuncture and needles, I'm probably not going to recommend that, even if that has the best evidence for their condition. So how do we best match the therapy for the context of the person that we're working with? So this is that ECHO model. Back in 1999, when I started my integrative medicine fellowship, one of the things I wanted to do was have some sort of clinical guide that my colleagues and particularly primary care medicine could use to really use integrative therapies that now we also call functional medicine in a way that gives us an understanding of what's the best evidence, what's the evidence of harm, what's the cost, and does it match the opinion of the person that we're treating. It had never been done before, but I thought it's really important that we combine the evidence of benefit and the evidence of harm, because many of the therapies that we prescribe in functional and integrative medicine have little harm. And that needs to be brought into the equation, not just the power of the evidence, but what's the power of the potential harm. And if something has little harm and moderate evidence, then that should maybe be used before something with little evidence and more harm. So we created this evidence versus harm icon. And the evidence versus harm icon has the SOAR criteria, the strength of the evidence, the strength of the research, SOR, compared to what I made up was the evidence of harm, because we didn't have a tool to look at evidence of harm. So grade A evidence is meta-analysis human studies. So that's usually the pinnacle of the best evidence we have. We have multiple studies showing a trend of something that's beneficial. B is a well-done human study. So we may not have a meta-analysis, but it's a really good, well-done human study that we can look at over time to say, hey, this seems to work. And then C is expert review, expert opinion. A lot of what we hear is expert opinion. Lowest rating of evidence, but also not without benefit. That's the ABC of evidence of benefit. Then we have the evidence of harm. 1, 2, 3. 1 is the least amount of potential harm. 1 is like going for a brisk walk or eating broccoli. Very little risk of harm. Just don't get hit by a car. But generally, those therapies have a very low risk of harm. Number 2, reversible harm. So most supplements, not all supplements, most pharmaceuticals have reversible evidence of harm, that when I stop the intervention, often the body will repair and find its homeostasis or its return to balance. 3 is the potential for irreversible harm. Cardiothoracic surgery has the potential of irreversible harm. And birthwort, a very powerful yet potentially toxic substance, has little evidence to support immunity and a lot of potential harm. So that would get a rating of a C and a 3. And then we weight those against each other. So the better evidence with a less potential harm, the arrow starts to go upward. So the best therapy is one with the best evidence with the least potential harm. Then we have A2 and B1, maybe less evidence, but no harm, or good evidence with some harm. The arrow points this way. And then A3 is really good evidence for benefit, but also potentially having irreversible harm, or B2 or C1. Those are the horizontal arrow. We rarely get to the ones that are downgoing, but sometimes we do because we generally wouldn't recommend those. But sometimes we do. Sometimes there's an important surgical therapy that without it, they would die, but it has irreversible harm. So that's where this icon doesn't work really well. When you have one intervention that's potentially life-saving, but we don't have good human studies, but they would die without it. That's where this icon fails. But this works really good for low harm, low risk, good evidence or not so good evidence. When we have something like eating good nutrition with the weight of low potential harm, then that informs our medical decision making. And that's what we've put through the 5 editions of the integrative medicine text that I edit along with my colleague now, Vinny Minichiello, who's my co-editor. So I wanted to explain that as a guide. Remember, as Osler said, this is an art based in science. This is a science that guides us, but this is the art. So that context, that unique human experience within their environment really directs the therapy, but then the evidence guides it. Now, we're seeing an explosion of artificial intelligence and a lot of these large language models. So as I edit manuscripts for a lot of the medical editing I do, there's different quality of large language models that helps us with medical decision making. Gemini isn't bad, but it's a little old. It's usually a little outdated. I think the data set's usually about 1.5 years old. It has no citations, and it takes information from popular common websites that may not be based in science. This is probably my least favorite one to use for medical decision making. The next better, that still is not great, and these may come and go as time passes. But right now, in February of 2025, Perplexity is a little bit better. It combines both evidence-based journals as well as the lay press. The challenge with that is the lay press actually may negate some of the evidence. And then the quality of the journals often isn't taken into effect. So I put a common query in here that I have done a lot of research and know a good amount in regards to literature on this topic. What is the potential long-term risk of chronic acid suppression with PPIs? So I feel like I have a really good understanding of what that is. So I can check these large language models. And the challenge is, if you look at a drug, first of all, the quality of the journals. Let's look at the quality of the journals. I've never heard of this journal. It might be a great journal, but I've never heard of it. So there's a little bit of a concern there because the Perplexity large language model doesn't look at the quality of the journals or the evidence when it brings it into account. The other thing is when it includes the lay press as well as academic journals, it risks bias. For example, PPIs are one of the most commonly used drugs by our gastroenterology colleagues. So naturally, they would be a little implicitly biased towards continuing this form of medication. And that bleeds into the recommendations that Perplexity provides. It says the American College of Gastroenterology states that long-term PPI use carries more inherent benefits than risks for appropriate indications, but the possibility of adverse events cannot be completely excluded. I would argue that we do have good evidence to show it, and there's very few actual indications for long-term PPI use. Solinger-Ellison syndrome, recurring peptic ulcer disease, even Barrett's esophagus has not been found to go to adenocarcinoma with PPI use. There's a lot we just simply don't know. But the evidence for potential research for harm is just growing and growing. So my favorite right now is open evidence. Open evidence only searches PubMed. So you reduce the bias is science, right? So in order for it to be included in this large language model, it has to be cited and published in PubMed. So at least you have the confidence that this comes from the medical literature. The risk is it might lead some gaps. It might leave things out. When I looked through this, it included most things, but actually the research on dementia has not proven out. PPIs have not been shown to, without a doubt, increase the risk of dementia, but they sure increase the risk of malabsorption, increase risk of community-acquired pneumonias, C. difficile, colitis, etc. So this is not 100% accurate based on what we have. But the nice thing about open evidence is it gives you the citations. So you can just pull the citation and look at the quality of the journals right from the search engine that it uses. But still, the best thing is a well-informed human that knows the literature and then can take that knowledge and combine it with these large language models to have the best recommendation. So this is a list of a lot of the studies that I've published on the potential harms of chronic PPI use. Again, great drug short-term, long-term risk. We should be a little careful. What the research shows, particularly in the VA large data research, is the longer the use, the more potential harms, particularly in regards to major adverse cardiac events as well as chronic renal disease. One of the thoughts is, and this is a hypothesis, we don't know for sure, is that the macrophages, the chimney sweeps of our endothelium, work by these lysosomes. So lysosomes lyse things by creating an acidic environment. So the broom of the chimney sweep is a lysosome, and if we shut that off with proton pump inhibitors that really don't care where in the body they're inhibiting these proton pumps, we might actually turn off the self-defense mechanisms of one of the most important immune cells that clean out the lining of our endothelium. And if there's any part of your body that you want to maintain health, it's our endothelium. So this is a little concern. The human bit puts the evidence into context again. By far, this is the ideal. So know your stuff and use these tools because they're just going to get better and better as we move up. All right, let's pick a few areas in regards to looking at this evidence versus harm icon model. So the first let's explore is low-dose naltrexone. Low-dose naltrexone, initially I was a little I questioned it, but then I looked at the echo model and I said, what's the evidence of benefit? Actually, there's some promising studies. The initial studies showed that you needed a state of inflammation for these to work better. They didn't seem to work if there wasn't a high SED rate or a C-reactive protein. That if someone has fibromyalgia and their SED rate or C-reactive protein is high, they're more likely to respond to low-dose naltrexone. What's the cost? Not that expensive. What's the harm? Not that harmful. It's low-dose naltrexone. We give 50 milligrams for alcoholism. We're prescribing 4.5 milligrams tops for low-dose naltrexone. So the potential risk of harm is actually quite low. Hey, an opinion? You have patients with fibromyalgia who are suffering. They want anything that will improve their quality of life. So generally the opinion, the evidence for benefit is not great. It's grade B. We have some good human studies, but not a lot, not enough for meta-analysis. We have potential harm. Low-dose naltrexone can cause excessive dreaming and other side effects, just like any medication, but the effect is much lower. And patients want it, particularly if they have this condition where their sensitivity is turned way up. So this is a study looking at how low-dose naltrexone might work. And if you look at the brain, there's these microglial cells, and they surround these neural networks and our neurons and our synapses. And think of it as the radio dial that turns up the sensitivity for pain. That happens through the microglial cells. And one hypothesis, we don't know for sure, but one hypothesis is that low-dose naltrexone might turn down the hypersensitivity and even the number of microglial cells. So when you have someone with a hypersensitive state, that's not a bad thing. That's a good mechanism. A hypersensitive state, that's not a bad thing. That's a good mechanism of action. As we go, there's so much we don't know. But right now, it's something I prescribe with my compounding pharmacy because it meets the echo model. We have some evidence, grade B. We have very low potential for harm. It's not that expensive. Patients can afford it out of pocket. And generally, people want it. It matches their opinions and their mutual goals that we have through shared decision making.
If you're a licensed healthcare practitioner ready to evolve your functional medicine practice, explore over 300 hours of clinical training, masterclasses with leading functional medicine clinicians, and certification pathways. Or check out the Academy of Functional Nutrition and Lifestyle Medicine at afnlm.com. Whether you're on the path to certification as a functional nutritionist or simply want to optimize your own and your family's health, our skill-building approach builds real-world competence from the ground up. And lastly, if you're dealing with chronic health challenges, visit drknews.com for self-paced courses that help you understand and address fatigue, brain fog, autoimmune conditions, gut problems, and more using evidence-based approaches. The content on this podcast is for educational purposes only and is not intended to diagnose, treat, cure, or prevent any disease. Always consult with your healthcare provider before making any changes to your health regimen. Thanks for listening, and don't forget to subscribe and share with someone who might benefit.